it was interesting for me to hear the first two talks this morning where there is not a general consensus about a framework. There is also no general consensus about adaptive designs, and so I will hopefully try and give you my view of the key points in adaptive designs, which maybe you can take home and use some of the methods or think about some of the methods. So an outline for my talk is as follows. I want to start by just talking generally about what is meant by adaptive designs in the broadest context. I then want to give a general overview of some procedures. This is the way that I like to think of adaptive designs, in that it's linked to different objectives in a trial. So I'll talk a little bit about the objectives, and maybe you might recognize these from some of your own work. And then I'll talk a little bit about advantages and disadvantages. Despite my profession as a statistician, I promise you no formulae, although the occasional Greek letter may sneak its way into some of my slides. So I then want to talk a little bit about adaptive designs in practice, and to give you an example of a trial that I'm involved with in an NPI as a member of the Data Monitoring Committee, and then to end with some conclusions. So if you look in the literature, there are a broad number of general definitions for adaptive designs, but this is the one that I like the most. I think it's quite succinct. An adaptive design is generally a trial or a design which incorporates interim analyses, where data as part of that trial are examined in order to make a decision concerning the rest of that trial's conduct. So these can be very simple, and if this is your first time in hearing about adaptive designs, I would recommend you think about the simple cases first, because they don't have a great deal of controversy associated with them. They're fairly simple to implement, and they don't have too much in the way of consequences for monitoring or analysis. But they can be very complicated, that's the other end of the spectrum, and then they do have huge consequences for monitoring processes and analysis. So there are many approaches, and there is a great deal of terminology, some of which I shall aim to demystify today. So, as I said, there are four general kind of types or objectives of interim analyses in adaptive designs that I like to think about. I'm focusing mainly on what I would call confirmatory trials, so maybe the sort of late phase 2 that we heard about earlier, phase 3, rather than learning trials, which would come under the phase 1, phase 2A. So I want to talk a little bit about estimating nuisance parameters, stopping for futility and efficacy, trials involving selection, and modifying the allocation rules. So each of these are types of adaptations that you might want to think about. So the first of these is the estimating nuisance parameters, and as I said, there is a great deal of terminology in the field of adaptive designs. I've just put up some of the words up there. So sample size reassessment is the main sort of statistical term that you might hear, but there was a lot of debate about blinded assessment or unblinded assessment, maintaining the power in designs, looking at estimation of success rates or event rates in the trial. So what do we mean by this idea that the very simplest thing that you can do in adaptive designs is to estimate the nuisance parameters? So for most of the later phase 2 and phase 3 studies that I was thinking of, we are including a comparator in those types of studies, and we would usually perform a sample size calculation. They depend on assumptions, and they depend on parameters. The value of these parameters, they have to be guessed. So sometimes we've got earlier work, we might have pilot studies that can give us some values for these parameters, so things like variability or overall success rates. Sometimes we don't really know what those things are. We put these values into our sample size calculations, but we're not exactly sure where those numbers have come from. And if we don't do anything, if we don't adapt our trial at all, then we just take these guesses and say that's the best that we know, and we recruit those patients and wait until the very end of the study to be able to do the analysis. But I always think that's a little bit dangerous, particularly in the setting where we don't know too much about the assumptions and the parameters. So this very simple first step into adaptations is something that's worth thinking about. And that's what's known as a sample size reassessment. So what we do in sample size reassessments is that we look at the assumptions and we look at the guesses, we check them partway through the trial, and then we adapt our sample size, if it's appropriate, to reflect our new information. In most cases, this can and should be done without breaking the blind on treatment allocations, if you can do that, obviously depending on what is being studied in terms of the intervention. But there are methods for doing it blinded, and there are methods for doing it unblinded. So as I say, a little bit of Greek, but not too much. I wanted to just show you that the sample size re-estimation approach really is quite a straightforward thing to do. So I've got a hypothetical example up here. So it's a trial with a type 1 error rate of 0.05, a power of 0.9. The clinically relevant difference that we're looking for in this example is 0.5. And we've guessed that our variability is a sigma squared of 1. So we put that into our sample size calculation, and here is my sample size that I need, 168. If we left that and just went and recruited 168 patients and did an analysis at the end of the trial, that would be the usual way to do a two-arm comparison. But suppose after 80 patients, we calculate an estimate of the total variance in the sample, so we're doing that blinded. We can use that to re-estimate our sigma squared via an appropriate formula, and then once we've got that, we can put that into our new calculation of sample size, and it might be, say, 304. So that difference from the 168 to the 304 in this example that I gave you was only from a very small difference in that total variance. The 1.0 was up there at the top. The total variance I estimated was about 1.4. So not a great difference in the variability, but quite a large implication for the sample size. If we hadn't included this adaptation, then we would have risked an underpowered study, and we would have been in the situation that if that true treatment difference had been there, we may not have found it. So the sample size re-estimation approach is something that's been in the literature really for about the last sort of 30 or so years. A lot of the design characteristics and the consequences for the type 1 error rate and the power have all been evaluated. There's methods that are out there which strive to ensure that there's minimal impact on your type 1 error. That's often what people are worried about when you go into this idea of using adaptive designs. As I say, there's methods for blinded data, there's methods for unblinded data. The methods of analysis that you're used to using at the end of a trial, they're usually implemented and they're usually reported because the impact is very slight on the design characteristics. I hope you agree just from that simple slide earlier that they're relatively easy to compute, relatively easy to carry out, and they're not too costly in terms of administration. So as I said, I was going to do advantages and disadvantages, but when I came to sit down and write these slides, I must admit that I couldn't think of any significant disadvantages for sample size reassessment. If you conduct it appropriately and follow the appropriate techniques for doing it, then I think one of my messages from this talk would be it's something that you should consider thinking about in your studies. So that's the first type of adaptation, the simplest one. The second of the adaptations is one which again has been around for quite a long time, and it's predominantly characterized by what's known as group sequential designs. But you can see from the number of words that I've put up there that there are an awful lot of different approaches for doing adaptations based on this idea of stopping for futility and efficacy. So there are combination testing approaches, there are conditional power approach, there are promising zone approaches. I said we was, as much as you had the differences in framework, we have differences in the type of methodology for doing this one thing, this idea about stopping for futility or efficacy. So how do we move from this idea of a sample size reassessment, which is the idea of looking at estimating a nuisance parameter, to thinking about stopping our study? Well, it came really about from thinking about why limit the review of data in your study to revising just the sample size. There are ethical reasons for patients, if it's possible to conduct a study quicker and if there's sufficient evidence available to stop. There are economic reasons for funders to, again, if it's possible to stop a trial earlier when there's sufficient evidence, then that can be a good thing. So what we want to try and do with this sort of first move into a slightly more complex adaptive design is to look at our emerging data periodically and then stop the study in one or both of these cases. So one, if one of the treatments is already better than the other, or secondly, for futility, and that may be very relevant if there's no point in continuing that study. So those are the two different sides of the coin, stopping for positive effect and stopping for a negative effect, or a no difference effect. You don't have to do both. Some people think that as soon as you move to group sequential designs, you're doing both of these things. You don't need to. You can have designs for futility, designs for efficacy, or both of them. But the key thing that moving into this next branch of adaptive designs promotes is the idea about defining some sort of stopping rule. We're now going to look at our data as we proceed, and we have to decide when we're going to stop. So the sort of general approaches to stopping rules, again, if you look in the literature, it can be a bit of a minefield for looking around all of these sorts of things. I've just put two examples up here which have come from genuine trials. So sometimes you can plot against the interim look. So remember what we've got now is we've got the situation that we haven't just done one sample size calculation. We're now going to do a series of interim looks at our data. So now we've moved from one dimension to two dimensions. So we can plot, as I say, we can plot against interim look number, so that's 1 to 5 up here, or we can plot against something else. We can plot against critical values that you might be familiar with from sort of standard type tests, so like the 1.96 that we compare with, so you can plot against that, or you can plot against something else. We can have symmetric designs, so the one on the left is a symmetric design. We can have a design like the one on the right, which is an asymmetric design. And we can have all possibilities in between. So the idea behind this stopping for futility and efficacy is a very good one, but it does open up this whole possibility of all the different things that you can do. And it's when you have to start thinking about the consequences of each of the different types of stopping rules that you might use, how you might use it, what you will monitor, how you will look at the different elements of the data. So that's the sort of general idea. The efficacy and futility is that we move into this two-dimensional world and we have these boundaries. Sometimes we're concluding that, on my diagram here, experimental is better than control. Sometimes we're concluding down the bottom that experimental is worse than control, and sometimes we're ending with a conclusion that there's no difference between them. But essentially, what we're doing when we implement these stopping rules is something like the following. So here is the diagram that you saw on the previous slide, but now we are monitoring our data. So each of those black crosses on that diagram is the results of an interim analysis. And at that interim analysis, we are unblinding the data in this particular trial. We're calculating a statistic which represents the benefit of the treatment at that point, and we're plotting it on that graph. So we would then continue our trial until we cross the stopping rule or the stopping boundary. And so in this study, this was a study of stroke patients, and we crossed the upper boundary with a final sample size of 648. This stopped earlier than the equivalent fixed sample size trial, which had a sample size of around about 850. So that is one of the benefits of these adaptive designs. When you start to look for efficacy or futility, you may well stop earlier than the equivalent fixed sample size trial, but then again, if your evidence isn't so strong, you may go on longer. So So advantages of these types of designs, again, this is widely written in the literature. It's good potentially for a patient because it avoids randomizing patients to treatments which are already inferior. It can mean that we can make a successful treatment available to other patients much quicker. So if we were to do one of these studies and stop early for efficacy, we can get that treatment out to the wider patient population. It's good from a funder's point of view because if we stop for futility, we can avoid wasting our resources. And it's good for motivation. We're now not leaving these studies just to move along over a period of time until we look at the data at the end. We're now looking at the data in a formal, organised way and being able to make some conclusions about it. As I said, these types of methods looking at efficacy and futility have been available for a number of years. There's readily available software, and I'll say a little bit more about that on a later slide. But with the increasing flexibility, there does become more in the way of disadvantages. Because we're having to define these formal stopping rules, it's harder to plan and to schedule them. How many interim analyses do we want? There's a question to start off with. When do we want them? How are we going to link them to patient recruitment? What are we going to do if patient recruitment is slower than we anticipate? Because we don't do that very simple sample size calculation to start off with, it's much harder to budget for. So it's dependent on the ongoing results. So particularly in the case of public funded trials, that can be difficult to be able to source finance when you're saying, actually, I'm not sure how much this trial is going to cost me. It could cost me X, or it could cost me Y, or it could cost me somewhere in between. I'm not sure. There's often concerns about unblinding the data. So who's going to do that? Do you have to do that through an independent setting? Does somebody else that's independent of the trial need to do it? If you have a data monitoring committee, what do you tell them? What information do they get? How much do they need to understand the nuances of the adaptive design? And then there are implications for the analysis as well. So that's a sort of second of the sort of adaptive design sort of scenarios that I like to think of. Then moving into the third, we're getting more complicated again, but this is the type of study which is becoming much more researched in the literature. There's much more interest in it from people that are conducting trials, and that's the idea of having a trial which involves some sort of selection. So treatment selection is a title you often see in papers, or you might see multi-arm, multi-stage, or enrichment designs is another word. So this sort of progression of how things are working, the efficacy-futility idea was just this idea about simply stopping. Now we want to think about, can we actually, as well as allowing simply stopping, do something else with our interim analyses? So could we design trials which allow dropping of treatment arms if we have several of them to start off with, and that may be particularly relevant for NPIs? Or could we want to look at trials which add treatment arms? Do we want to do subgroup selection? If it seems to be working in one group of patients, can we find that out as part of the trial and adapt to that information? So these types of trials that involve selection, they're conducted in several stages. So they have early stages which sort of refine the questions. So that's like the sort of 2B part of the traditional sort of phases. And then the later stages do the phase 3 part, which is the definitive evaluation. So you may see literature that talks about phase 2-3 designs. And essentially what that's doing is this idea of putting some element of selection into a study. So the general idea behind treatment selection designs, which may be relevant to some of your sort of settings, is this idea that we start with a number of treatments. I've got a T1 to TK there, which is a number of treatments. I've got a T0, which is a control. At the first look at my data, I keep my control, the T0, but I order the other treatments. So T1 in brackets is the one that's currently doing best. T2 is a close runner behind, and TK down the bottom is the worst. Now, I could just select the treatment, which would be to go through the arrow in the middle, but what I could do is actually bolt on the ideas of efficacy and futility that I had from my other type of adaptive design. So I could allow stopping for superiority or futility at that aspect. I could also bolt on a sample size reassessment if I wanted. So these different types of adaptations that I've been explaining aren't all independent. They can happen just one in one trial, or we could put them together. So here this example has got selecting through the middle or doing stopping for either side. Then we do another interim analysis and reorder and carry on in the same sort of way. So you can see that these are getting much more complicated, but they're also potentially getting much more useful for certain indications. So that's the idea of what we would call treatment selection designs. Another popular type of design is what's emerging now, is what we're calling subpopulation selection or enrichment designs, if you know that term. The idea is at the start of the trial, you give the treatments to the full population, but within that full population, there's a subpopulation for which it maybe potentially benefits more, and those that are not in that subpopulation. And then you can perform one or more interim looks, where you may continue with the full population, so that's down at the bottom of that diagram, or you may then decide to just go forward with the subpopulation. So there are a number of advantages that have been cited for these types of designs that involve this selection element. It eliminates the delay between these sort of learning and confirming phases. Traditionally, within sort of pharmaceutical development, they've been separate, but if you join them together, then you're bringing both of those elements into a single trial. And that has efficiency gains from using the early data in the overall analysis at the end of the trial. You're going to use less patients overall, which can be viewed as potentially a good thing. You write a single protocol rather than your phase 2 protocol and your phase 3 protocol. And you have the ethical and economic advantages that we saw for the sort of futility and efficacy stopping if you include that element. So you don't have to, you can just do a full trial that involves selection, but you can incorporate the early stopping as well. But the disadvantages, they're actually often seen in this setting as the opposite of the advantages. Some people will argue that, yes, you put the two phases together, but now you've lost your thinking time between those two phases, and you've lost the independent replication of the studies. Often the positive results in that phase 2 study can help recruitment of either patients or investigators into a second trial. You can't release those now because it's all part of the same trial. I said that you get efficiency gains, which reduces patient numbers in the trial, but then you have less total experience of the treatments used by the patients. So the advantage and the disadvantage are opposites. And then all the sort of planning and the budgeting and the analysis and all of the things that we had for the futility efficacy disadvantages translate and potentially become more complex in these these designs with selection. So the last of the types of adaptation is one which is not often seen by a lot of people in the literature, and it's the idea of modifying the allocation ratio. So the key term there would be response adaptive designs. And what we do in this idea of modifying the allocation ratio is, remember, adaptive designs are using data as we go along. And what we do in a response adaptive design is that if one treatment is starting to look potentially inferior, then we randomize less patients to that treatment as we go on during the trial. So we start with randomizing patients normally in a 1-to-1 allocation ratio, and we would vary that allocation ratio throughout the trial depending on the ongoing knowledge. So a general approach, if you've not seen this before, we start with essentially, we call it an urn model, so that's got equal numbers of red and blue balls in my urn up there. We choose a ball at random, say it's a red one. If it's red, we give the next patient the experimental treatment. If it were blue, we would give them the control. We put that red ball back in, we see how that patient responds to the treatment that we give them, and we change the allocation ratio depending on whether they were a success or a failure. criteria. So if they were a success, we put more red ones back in again, and less blue ones, or the other way around if we do it. So we're not all sat there with our urns. I promise you, the statisticians don't have a large jar for doing these things, but we do have computer packages that implement this idea of adaptive randomization. So advantages, that's relatively easy to implement. It can be used with different types of design, so parallel group is when it's mostly used, but you can implement it with others. And it has ethical advantages for patients in that trial, because it's those patients' experiences that are determining the allocation ratio for future patients in that study. Disadvantages is that most of the methods require a decision very quickly, so we need to know the response of that patient to be able to change the allocation ratio, so we need something that's readily available after treatment administration. And another argument that's often put up there is sort of, well, is it worth reducing the numbers in that trial itself? Surely we should be worried about patients outside of the trial, and if patient outside of the trial is what we're thinking about, they're best served by keeping the trial as short as possible, which we can do through a one-to-one allocation ratio. So those are my four broad types of categories that you can have for adaptive designs. As I said, you can glue them all together, so you could have a design that has sample size reassessment, stopping for futility and efficacy, with some treatment selection and a sample size and a randomization allocation element to it as well. But in practice, there have been an awful lot of examples in the literature over the years, mostly of the group sequential designs, but more recently we're seeing a lot more interest in the treatment selection. There was a recent survey that was published. It is in the sort of pharmaceutical, the regulatory setting from authors at the European Medicines Agency, but they found that the most popular form of adaptation, not surprisingly, is a sample size review, and that's being much more routinely used in studies that they're seeing. Examples in a sort of a non-pharmacological intervention setting is a study that I'm involved in on the data monitoring committee, and this is the PROVE trial, which is a study that's looking at the management of 3 strategies for osteoporosis patients who have clinically diagnosed vertebral fractures. So this study is a 2-stage, there's 2 interim analyses, it's an adaptive design, it has treatment selection and the possibility of futility stopping. So that's what the authors picked as the adaptations that they were interested in. So they're comparing usual care, which is a single session of education and advice, to the second arm is 7 individual exercise-based physiotherapy sessions, and the third arm is 7 individual manual therapy-based physiotherapy sessions. So they also have the additional complication that they're looking at 2 endpoints. So stage 1 of the trial looks at the Qualifo 41 score at 4 weeks, and at that stage, if the 2 physiotherapy arms are very close to the usual care arm, they're going to stop the study for futility. If one or other of those arms is doing much better than the usual care arm, they're going to keep one or both of them in the study to stage 2. And that again is looking at the Qualifo 41 score, but it's based at 12 weeks this time. And this is being used with a standard method that's available in the literature. It's based on combination tests, but it is this idea of what do you want in your study? What adaptations would be good for me to think about? And can I use them, and can I put them into practice in my trial? So as I said, there's a little bit here just on sort of software. There are 4 packages that I know of that do these different elements of adaptive designs. If you go on their websites, you'll see a lot of the terminology that I've mentioned. The East package is developed over in the States, and that's probably the largest of the packages. The other packages have sort of been coming on much more recently and have different elements included in them. I put a little bit just on sort of regulatory considerations. There are 2 guidelines out there. I don't know if you look specifically at these, but there's a reflection paper on issues in confirmatory trials that use adaptive designs, and also an FDA guidance document that looks at adaptive designs in drugs and biologics. So just 2 slides to sum up, really just to give you some general conclusions and to hopefully give you a couple of take-home messages to think about. So in your studies, if the one thing that you want to think about is, have I got this sample size reasonably correct, then I would encourage you to think about this idea of estimating nuisance parameters. The double ticks over on the right-hand side suggest that this is fairly well accepted. It's relatively easy to implement. If you can avoid breaking the blind, then do. And you can look at methods. Some out there in the literature don't do very well, so you need to look at methods that make sure that type 1 is protected. If you want to think about stopping for futility and efficacy, again, the 2 ticks are to illustrate that that's relatively well established. You've got to plan it in advance, so you have to do your stopping rules in advance. You need to clearly explain which approach you're taking, so from all of the literature out there, which one are you going to use? And again, you need to make sure that your type 1 error rate is protected. The trials involving selection get 1 tick because they're more emerging designs. They're increasingly being considered for trial designs. You have to clearly justify exactly what you're doing. What elements of the selection do you want to look at, and think about that in advance. And again, the type 1 error rate is a concern. And the final one, which is my modifying the allocation ratio, that's been round for a number of years, but there's much less said about these types of designs. It might be that it's these continual interim analyses that are an issue, or it might be there's this danger of revealing the observed treatment effect. If more people are moving over to one arm rather than the other, then you start to learn a bit about how your treatments are performing. So thank you very much for your attention. I think we're saving questions to the end, aren't we? But thank you for listening.